Good morning, everyone. I got 9 o'clock. To be respectful for everybody's time, we're going to get started. Thank you. Welcome to June EMS audit review for Union Hospital. As you can see the agenda on the thing on the screen, STEMI report by Brenda. Brenda actually texted me this morning. She's sick, so I'm going to try to do the STEMI report. I'm sure I'll mess it up, but we'll have to deal with it. If you are online, send me a text and email something. Let me know that you're there so I can get your name on the sign-in sheet. Just so that you know, we have people in the audience. Starting today, we are going live, back face-to-face and Zoom both. I will still put this up on YouTube like normal. Next month in August, understand we will be having the meeting in the atrium, as if, you know, if y'all want to show up live, you're welcome to do that. So just want to let you know, the people here are eating breakfast. Did I throw that out? You know, yeah, EMS says if you got food, they will show up. So that's the way it is. All right, so we're going to moved right into the STEMI report. So, all right, so Brenda says that they have a a 0344 dispatch via 911 for a home for 60-year-old man that woke up with chest pain, left arm numbness, feeling sweaty and cold. Not a really good thing to wake up to chest pain. Arrived to find patient sitting in a chair, living room, accompanied by his wife. Wife Stacy woke her up with chest pain. Patient is now stating he is fine. The pain was gone away. Does not want to go to the hospital. EMS was able to talk the patient into at least allowing the exam in the ambulance, to which the patient agreed. Once you get him in there, you can sneak him out. That's it. It's just not good. So, 046047, the 12 lead that you showing elevation of V2 through V5 and depression in lead 3. BP 164 over 121, little elevated. 97% room air. Heart rate is 75, respiration 16, blood sugar 147. Rating of pain of 9 to 10. Tympanic, so it was 0, right? Pain went away, didn't want to go. Now we're at a 9 and 10. Right? Tympanic temps 97.4. Aspirin was given 20 gauge left AC, O2 given via nasal cannula. EMS explained to the patient that he appeared to be having a heart attack and needed to go to the hospital. He did agree, which is nice. Good job. 0415, they gave nitro. All right. No change. 29. 0429, a second nitro is administered. Improvement with patient stating the pain went from 9 out of 10 to 7 out of 10. Vitals rechecked again. Blood pressure did come down as expected. Heart rate's down a little bit. Respirations are good. O2 saturation 100% on 2 liters. They noted that they continued to monitor the presentation, vital signs en route with no other significant changes noted. Called STEMI alert Union via IHERN with a 12-minute ETA. Unable to transmit 12 lead due to equipment issues. All right, so that stinks. Hopefully we can start using eBridge. That would work really well. So 0452, arrived to ED, placed ER trauma 2. Gave report to RM with attending ER physician present for verbal report. Obtained signature of the patient. Morphine, Plavix, Zofran administered by ED per cardiologist. Recommendation, patient denies cardiac history. Only history is an appendectomy. 0545, patient arrived in cath lab procedure. It was noted that the delay in the PCI was due to physician completing emergent STEMI at regional hospital. That's terrible. And minor delay verifying STEMI and cardiology due to technical difficulties transmitting the EKG. A balloon catheter advanced across the target lesion at 0625. 0628, 2 drug-eluting stents advanced to target vessel and placed in overlapping fashion to cover the entire calcified and very hard diseased segment as noted by the cardiologist. Total occlusion of the left anterior descending artery LAD resulted in an ST elevation MI, treated successfully with excellent angiographic results. 2 candidates, patient candidate for medical treatment, risk factor management, discharged 2 days later, door to balloon time was 93 minutes. Great job of convincing this person to go to the hospital. And I would have 100% kudos on that. I mean, that's amazing, because this guy probably would have died at some point in time, maybe not that very second, but it would have not been good. So great job to the EMS team that did that. Not sure who it was, and we don't need to know who it was. Just great job that they did. So, daughter balloon right now we're sitting at 92% year to date. That fallout in April, but I'm sure we'll bring that back up throughout the rest of the months. Thanks for everything you do. That's for Brenda. Next is going to be Beth. She's going to do our primary stroke studies. Beth Harrison is
Good morning, everybody. Case I have today is she's an 88-year-old female. She does have a prior history of stroke and status post-carotid endarterectomy just about a year prior to having the stroke. She was not on any blood thinners, only aspirin. She was found sitting on the couch by her daughter in her home, and the patient was able to speak, and they said she was very glassy-eyed and staring at the wall. Her last known well was approximately 40 minutes prior when she spoke to her daughter on the phone without difficulty. The family did notify EMS about 13:31. They arrived at the scene at 13:50, departed at 14:02, and arrived at Union at 14:14. EMS documented her stroke scale was non-conclusive and no stroke alert was called to the ED. The patient appeared alert and oriented. She seemed to follow commands, but she could not verbally speak to the ED. Her grips were equal at that time and no facial droop. This is when at the EMS when they were at her home. She did have a history of hypertension. Her blood pressure at that time was 200/100 and a glucose of 136. When she arrived at the ED department, the patient did have a facial droop and was aphasic, but would follow commands. Her NIHSS in the Union ED was 8. I know EMS uses a Cincinnati scale or a band scale, but in the hospital we use the National Institute of Stroke scale. Her CT of the head was completed without contrast and no bleed. She was evaluated by neurology and was a TPA candidate. We did TPA the patient at 14:48, and that is a 34-minute door-to-needle time, which is pretty spectacular. You know, the very end goal for us is 30 minutes, but at 34 minutes is really a good TPA. Since her NIH still remained 6, and she had that prior, and she maintained that after her TPA, a CTA and a CTP were ordered to rule out to see if she had a large vessel occlusion in there. And if she did, we could have done a procedure to try to remove that. Here's a scale. This is something that we do with all of our TPA graphs. We go in, plot it out, and starting from the time they hit the door to get that first stroke order to the TPA was given. It lets us look at the good, the bad, and ugly. Lets us look at what things we could improve. It shows what we did very well, so we know where to focus our energy to make our TPA times better. We did use our rapid software, which is a great tool that we have. When we do that CTA, the CTP, we can see how big that stroke is, the core of the stroke, and how much penumbra or salvageable brain we have from the stroke. And we did do that. Her CTA showed a new infarct in the left frontal lobe, and it was reaching to the periphery of the lobe. The CTP did show a small core infarct and only about 1 millimeter of an ischemic penumbra. So she did not have much brain that we could save. And she was not, where the stroke was at, she was not a candidate for any kind of thrombectomy or any kind of treatment for that. After this, she was admitted to the ICU, was doing very well. Then in 00:51, there was a change in her condition. And we took her down for a CT scan, an MRI, and it did show she had a hemorrhagic transformation of her ischemic stroke. So she did end up bleeding into that area where she had her ischemic stroke. She did not end up with the shift. It was pretty much remained a small stroke. She was very lucky. She had multiple CTs after that to monitor that. There was no worsening of the bleed. She was able to regain a significant portion of her speech with some therapy, and she ended up being discharged home with home health care, STOT, and PT. So she did very well. And I really think, we got her here quick. And the documentation highlights and opportunities we had with EMS. Stroke scale was documented as non-conclusive, and they did not call it stroke alert, but the EMS put a very good narrative note in. And their diagnosis all the way through was stroke, and they really did a great narrative charting, but calling that stroke alert helps us know that if we're going directly to CT, helps us maybe get that CT cleared, that if we think we have a large vessel, it really saves us time with that, trying to get that stroke patient and get that TPA admitted.
So Beth, on this particular one, would you think they should have aired on behalf of the patient and actually call for a stroke alert?
Yes, I do.
Couldn't hurt. I mean,
It couldn't hurt.
yeah, if they're writing narratives that are saying stroke, I'm thinking
anything stroke, yeah. And the patient was admitted to a room in the ED instead of straight to CT. The doctor and the nurse went in right away and thought with the aphasia and the facial droop had developed, they took her straight to CT from there, but we did lose a little bit of time. We probably could have hit that 30-minute TPA if they had called the stroke alert, but you know, it's not bad. 34 will take it. So she did very well, so thank you. You guys have any questions or anything for me?
You kind of touched on it a little bit. So like if a patient receives a TPA for the ischemic stroke, and then later they develop these like other occlusions or large vessel occlusions, are they still a candidate for thrombolectomy or interventional radiology?
Yes, usually what happens, if they have a large vessel occlusion, it usually happens before we give the TPA. That's usually where that clot ends up, usually in the MCA, somewhere in that territory of the brain. And yes, you always give TPA first, then we evaluate them with the CTA, CTP if their NIH is greater than 6. And if they do have and that does show that we have a large vessel occlusion, they are a candidate for thrombectomy. Right now, the closest place that does that is Indianapolis, Evansville, or Carl Clinic. So we're gonna have to ship a patient out for that procedure at this time.
Thanks, Beth. Appreciate it. Hillary.
Hi, good morning. Barry, if you'll just move my slides for me when we're ready.
Absolutely. Tell me when.
Yep, I'm going to cover this for Kale, so I apologize if I can't answer all your questions. He put this together and forgot that he was supposed to be at a conference today, so we'll get through them. Go ahead and move to the next one. This is a case 1, 73-year-old male, history of PCI STEMI 8 days prior to this visit. He got out of bed, wife heard a thud and found him unresponsive. Okay. EMS notified at 1:57, arrived on scene at 2:05, departed the scene at 2:45 and arrived at Clinton at 2:53. Ready? As you can see, they were dispatched for cardiac arrest. They found him lying in the bedroom on the floor. The fire department was there performing CPR. This patient had a cardiac cath and stent placement 8 days prior to this. Woke up and fell and got out of bed, falling to the floor. Wife attempted CPR. She was unsuccessful and did, of course, call 911. He was in VFib, defibrillated, and intubated. They did obtain an IO, place an IO, and then were able to give meds as well. I won't read all of those through. You guys can see them up on, but they did a lot of work at the scene, did great work, had great documentation. They did get Rosk and transported him to us, placed him in trauma 1, and was left in the care of the MD and the RN. Next slide. So he did have Rosk upon presentation to us at 2:56. He had a STEMI, and the one call STEMI was activated. He was tachycardic, had a soft BP, and they started medication for that. They had a central line placed. They verified his ET placement. He had a wound to the right elbow. They gave rectal aspirin, OG, and Foley place, and he was door in, door out in 22 minutes from us to Terre Haute. Next slide.
Okay.
So he was seen in the ER, waiting for the cath lab team to get there. He had kind of woken up a little bit, so he did have to be dosed with some ketamine, had a repeat chest x-ray just with all the movement that he had. He was taken to the cath lab at 3:50 with just that short time in the ER. And I apologize, they're working right behind me, so it's a little loud. He had a successful PCI of the LAD from 100% down to 0, and then was transferred to the ICU. So highlights, Ross going to fill great documentation on this case by EMS. I will let you know that family came back and was very grateful for the care that they received by EMS and the fire department on that one.
Awesome.
We can move to the next one. So this is a 76-year-old male, history of cabbage, hypertension, diabetes, and hyperlipidemia. Family had seen him that morning. When they came back about 6:30 that evening, they found him slumped in the chair and aphasic about 6:30 that evening and called 911. Next slide. EMS was called at 1906. They arrived on scene at 1916. They departed at 1932 and arrived to us at 1945. Next slide. They were dispatched to the 76-year-old male for a possible stroke. He was found upstairs in the home. He was found in the care of the Montezuma Fire Department when EMS got on scene. He had he was still aphasic. He was able to open his eyes and follow commands, but was not able to communicate. He was having an uncontrolled quick jerking moment of his arms and legs, and startled and jumped with loud stimuli. Daughter had been gone most of the day, returned home, mowed her grass, and then thought it had strange that she had not seen her dad, and that's when she went over, found him, and called 911. So as you can see, they had a little bit of difficulty getting him down. They had to use some stuff to get him downstairs. He was given O2. They were able to get a line. He was in first degree AV block, and then was able to determine he had no pain, was transported to USC emergently. They did have to call a stroke alert via phone because of the service in the county. He was moved to room 10, report was given, and care was transferred to staff. Next slide. Stroke team was at the bedside upon arrival. He did get moved straight to CT. He had a stroke scale score of 4. Vituity teleneuro was utilized and TPA was not recommended. He had a negative CT of the head and a CTA of the head and neck. Signs and symptoms did improve during his stay, and he was transferred to the Indianapolis VA. Highlights and opportunities on this one: a van assessment was documented, and the stroke alert was called in via phone just because of radio reception, and the team was able to be ready for that.
Hillary, thank you very much. For those of you that didn't realize, we have added some UHC cases. We're going to start putting in every month that we're doing audit review. We're going to be adding some things there that they are primary stroke also and systemic. So we're trying to make sure that we have everything. We have them in with ours. That way everybody is from all areas of EMS. So up next is going to be Jackie. She's going to do trauma.
All right. So I come from way, way back. We won't say how long back because then I will identify how old Kevin and I are. But years ago, I felt like we were put to the test. We'll be nice about it. So I want to make sure that we pick out opportunities to learn, but I don't want to go back to the way we used to do it where you felt berated, okay? So please know that EMS did a fabulous job on this case. But I think we forget about little things as we go through, warning signs that help us know that it's really bigger than it is. And we do it in the hospital too. We are forever on these guys saying, why did you call this a trauma alert when it really should have been? So this one was a 42-year-old male in a car crash. 911 was called at 0744. I will tell you, this was Darwin Road. So if you know Darwin Road, it goes down, it comes up. And so it's kind of got some blind spots in it anyway. They were dispatched at 7:45 en route at 7:47, on scene at 7:55, and left scene at 8:13 and got here at 8:24. So considering where they were at, the time of day, it wasn't bad weather, but just the time of day, that's kind of a busy place. So really the times are good. So call to dispatch was 2 minutes. They got en route within 2 minutes. They are on scene with 8 minutes. They're on scene to depart was 18 minutes. That's really good. And then departure to arrival in ER was 11. So the total time called to us was 29 minutes. So that's really good. So we did call it a level 2, and that was appropriate. And in the EMS report, it says that the patient was found sitting on the side of the road because he self-extricated. I know this because I dug a little deeper, but it doesn't say it in the report. He was in a Jeep and the top came off. So it was a little easier for him to self-extricate than most people. He did not have a loss of consciousness. He did have his seatbelt on. The airbag did go off. And he had a history of some spinal fusions, but he denied neck or back pain. Okay, this guy is a little bit bigger. He's a lot bigger. He's a pretty good sized guy. So I think a lot of stuff was going on, and the fact that his Jeep just rolled 4 times and he got himself out was probably the main focus at the time. So he complained of left shoulder pain. I would have missed it. He was the driver of the car. It rolled. He self-extricated. I would have said, oh, it's probably the seatbelt. And he's a big boy. He's a very big boy. He complained of left rib pain, and the medic actually charts no abnormalities or pain with palpation. Okay, so they put a C-collar on him, they help him get to the cot, he's in sinus rhythm. He's hypertension with the history, but I think we forget because they're like, well, I have a history of hypertension. Well, but the patient, first they go hypertensive, then they become hypotensive. But I think we forget those baby steps, those basic things that we learned so many years ago. So it's really hard to say, was it from the wreck or was it because he has a history of hypertension? And so we all get a little quick to blow it off. He was 200 over 118. His heart rate was 88, respirations were 18. He was satting very well. His Glasgow was good, and they drop an IV in. So what types of injuries do we think about when we have this kind of a wreck? He was he got struck in a Jeep, just a regular old Jeep. He rolls, okay? So with rollovers, you could have TBIs, you could have spinal cord injuries, you could have fractures, you could have all kinds of stuff, right? It's not really limited to any particular injury. He was struck in the side first because he spins, then he actually rolls because he gets in the ditch. So you got shoulder, pelvic, chest, all kinds of fractures. They could be bleeding internally or externally. They could have organ damage. All kinds of stuff could be going on, right? So he gets in ER about 8:30 in the morning. He says, my wrist hurts, my left wrist hurts, my right wrist hurts, my shoulder hurts. Well, that makes sense, right? Because what's the first thing you do when the airbags go up, right? So vitals are still a little bit up. His pressure's still a little bit up, not as bad as it was on scene. It's good, but it does remain high, okay? And room air, he gets as far as 100%. So he's got great, his vitals are okay, other than he's hypertensive. So we do a head CT, we do a C-spine, we do a chest, we x-ray, we do all the things that we do when we get trauma patients. He has a grade 3 splenic plaque. So we admit him to trauma here at Union. He goes through interventional radiology. He gets a little embolization over there. So we use that. It's really a better way to manage that laceration. At least helps him maintain part of that functioning and such. So he does very well. Goes to the floor. So grade 4 splenic plaque, it's getting into some of the vessels. Okay, so it's compromising the blood flow, and it involves at least 25% or more of that spleen. One of the warning signs of a splenic plaque is a left shoulder pain. I would not have caught that, okay? Again, they did a very good job with this patient. And it's easy to look at these after the fact and go, well, because we have all the answers, right? It's like getting the answers to the test. So, but just the little things that we remember from basics is left shoulder pain is a sign of a splenic plaque. So he complained of pain in his upper left abdomen. Nope, he did not. Did he complain of tenderness in the left upper abdomen? No, he denied it all. He denied it all, but he did have left shoulder pain. He was not confused. He wasn't lightheaded. He wasn't dizzy. So on day 2, he's stable. We do a CT, no complications. Day 3 gets a few gas bubbles in there. They think it might be an infection, so they start some antibiotics, send him home. 30 days post-op, he's still having some trouble with his belly and his shoulder. He's now got a lot of increased anxiety. He's got a lot of trauma from that wreck. They do an MRI. They found a small tear in his shoulder. 60 days post-op, he's doing some workups for the back surgery that he had because the car crash has now aggravated it. So again, fantastic job. I wouldn't have caught it. I would have been, oh, seatbelt. Oh, he's got hypertension. I would have done the exact same thing they did. But what opportunities do we have?
They get lines on this guy, Jack?
We got one.
No, I mean, what else are you gonna do for a clinic plaque other than bring him here anyway?
Dr. Lynch, anything?
I don't know, this guy could have been a level 1, you know, I
Well,
mean,
but for us in the field, doc, we're just a trauma alert. That's
Yeah,
what
we
we
don't-
do.
yeah.
So
yeah.
medics did not call the trauma alert. We called the trauma alert.
Well, that's something that we probably, there's an opportunity there.
He did well. He was a big boy in a small Jeep. He self-extricated. The top came off. I don't know if it had been a regular car or a truck. I don't know that he would have self-extricated. He did go down in that ditch on Robinson Road, if you know where I'm talking about. One line, it was a good line. He denied everything. I don't know, other than maybe the trauma alert. There's not a lot, honestly. There's not a lot that could have been done differently. But I just want to bring this case to us because it's easy to forget those basics, you know. Yep.
Interesting enough, he still could have been initially having his heart attack and had no spleen injury.
Yeah, yeah, and he was a big boy. He was hypertensive. Could have been into
Heart attack
stroke
causes
territory.
wreck,
Could have
you
been
know.
into a heart attack. Yeah, you could have done a lot of things. A lot of could haves. But again, it's easy to be a Monday morning quarterback. So but they did a good job.
He
Finding
never
it great.
needed a transfusion or anything.
He didn't because, remember this case, I think it was your case, actually. I think because we got into IR quick enough, we were able to stop the bleeding. Otherwise, he would have lost at least the spleen.
But he, at least like skin signs were all.
Yeah,
different.
I think other than the hypertension and the previous back surgery, I think he was otherwise a pretty healthy guy. He just was a big boy.
Jackie, thank you very much. Appreciate it. Next up, Christine Withrow is the pharmacist in the ER. And she is going to do some pre-hospital talk about ketamine, midazolam, and some other medications.
Mhm.
So it's time for her, so thank you very much. Stand up a little bit closer.
Okay.
And then-
Good.
All right, thanks for.
Okay, so. Like you said, I'm gonna be talking a little bit about a combination of things like primarily focus on midazolam and ketamine, as well as like touching a little bit on the pros and cons of our different routes of administration of different medications when they are most appropriate. And so first we're gonna go through the different medication routes, identify the different pros and cons, then compare the place in therapy of midazolam and ketamine, and then finally review some of how both of those medications have places in the EMS protocols. Okay, so some of our big routes of medication administration, and this is obviously not all of them because oral is a big route, but in terms of like our emergent care, these are some of our big routes, and that's going to be intravenous, intramuscular, inhalation, intranasal, and intraosseous. And really, when we think about all of our different routes of administration, how our medication works is going to impact whether or not a medication can be given by different routes, and how well that's going to work and how quickly that's going to take effect. So how quickly and how that takes effect is really dependent on what we call pharmacokinetics and pharmacodynamics. So pharmacokinetics is going to be the course of time that it takes for drug absorption, distribution, metabolism, and excretion, or ADME. But to simplify that down, basically pharmacokinetics is going to determine how long your drug is at your target organ site. So once our drug is at our target organ site, that's where pharmacodynamics ends up taking effect. And so that's going to be the relationship between the drug concentration at your target organ and like the way the mechanism works and how that's going to cause your results into effect. So in the simplest terms, pharmacokinetics is how your body affects the drug, and pharmacodynamics is how the drug affects the body. So when we're thinking about all of our different routes of administration, what's really going to determine whether or not a medication is ideal for different routes is going to be that first one, the pharmacokinetics, and so that ADME. So first we have to have absorption. So if we're giving a medication extravascularly, that drug has to be absorbed into systemic circulation. So depending on that route, it could be longer than others. So this is why intravascular administration is going to obviously be the fastest route, but that doesn't mean that our other routes are necessarily slow. And so that's something important to take into account. Next, you have to have distribution. So just because your drug's in circulation doesn't necessarily mean it's at the organ you need it to be. So you need that drug to leave the vasculature, get to your organ. And there's a lot of different factors that are going to impact the extent of distribution for different medications and like where it wants to be. And then the last is going to be your metabolism and excretion. And so like the half-life of the drug is going to determine the time it takes for your concentration to decrease by half. And a short half-life is often going to be related to a short duration of action. So most of everyone should be fairly familiar with intravascular administration, so I'm not going to go on this a lot or focus on this a lot. But it is going to, obviously, as we discussed earlier, circumvent the absorption phase, which will result in a faster delivery or faster onset of action. And because it's going directly into the vasculature, it's a little bit more of a controlled delivery and can be more accurate or predictable response. However, there's a lot of disadvantages of IV administration, and that primarily is going to be that it takes time to get an IV. If you have a patient that is volume depleted, sometimes it's a little bit harder. And so if you're waiting around to get an IV, sometimes it might have been faster to give that medication via another route, and it might have taken effect by the time you end up getting that IV and getting everything started. And then you also have to make sure the IV is placed correctly, sterility. And then also when you're giving a medication IV, you have to be careful about like your, you can't just push everything rapidly because that can cause adverse effects. And so you have to make sure you're being careful with like your speed of administration and whatnot. So next is intraosseous or IO administration. And so this is a recommended route of administration when IV access cannot be easily obtained for certain medications. And this is actually recommended by ACLS and PALS for an alternative to IO or IV, like especially in those like true emergency situations. So for IO, one of the things that we think about in terms of onset is it's going to be very similar to IV because it's still going very quickly into the vasculature. And you can basically treat an IO as a peripheral IV in terms of what medications you can give into that site. So you're not really restricted. Medications that you would give centrally, you don't want to give via IO, but that's why we treat it as the same as a peripheral IV site. And then because of some of like the resistance with IO, if you're going to infuse fluids into an IO, a lot of the times pressure bags can be ideal there. And then of course with IO, you also want to make sure you're ensuring that you have proper placement of that IO to prevent complications. And on that list on the side is going to be all the drugs that are administered IO. Obviously, it's going to look very similar to our list of all the medications that we can give IV. So pros and cons of IO administration. So big pros are that we're going to have a fast onset of action. It's not really different in terms of like our IV in terms of our peak effect. And then we can safely give most emergent medications via IO administration. It can also reduce time to administration because obviously if you have like a really critical patient, starting an IO is going to be a lot faster than like fumbling around with an IUP with some of these patients. However, you can have a lot of disadvantages. So if you don't place your IO properly, or you don't maintain well, if you don't place the IO properly, you can have infiltration of the drug, and that can contribute to compartment syndrome. So that's why making sure you have proper placement is very important, making sure you find your landmarks. And then if you don't use aseptic technique, you can also have a risk for infection associated with those IOs. The other thing is if you've ever placed an IO in a conscious patient, they are not happy about that, especially when you start giving medications. So one of the things that you can do, and this is part of the EMS protocols, is that if you're going to give a medication in a conscious patient, you can give that with lidocaine. And so you use the 2% lidocaine similar to like the one you would use for like in like a code for your like shockable rhythms. And you give it via slow injection and you let it dwell for 30 to 60 seconds before flushing or medication administration. And that helps to improve a lot of that discomfort that patients experience. The dosing is there on the bottom. If you have like a kiddo, you're going to do 0.5 milligrams per kilogram. Adults, you can go up to 40 milligrams.
So do you know if there's a preference between the tibia or the humeral head that's better than the other? I mean, I was just curious if there was any literature or anything about.
I'm not like super familiar with that. I know that like, if I remember correctly, I think it depends on like the age of the patient, but
mean, they're both viable
Yeah.
IO spots. I
When
was
they
just
first come
curious
out with the humeral head, they promoted that it was quicker because.
because it was directly into the
location.
subclavian, into the, yeah.
Okay, so next we have intramuscular administration. And so when we think about intramuscular administration, we have the advantages here that it's going to have a rapid absorption and a shorter onset compared to like an oral administration or sub-Q. And you have a decreased time to administration because obviously you don't have to start any line and you can just give it in the muscle. But the disadvantage is if you choose your wrong needle length and you end up giving that injection subcutaneously, that drug is going to have a much slower absorption. And so it's probably not going to take effect the way you want it to. And then you also have to be cautious on what volume you're giving in what muscle. So on our next slide, we have our tables of all of our different muscles that we can give like IM injections in. And so, for example, our deltoid, we really typically don't want to give more than 1 ml in the deltoid. So if, for example, you're giving a patient IM ketamine en route, that could be a larger volume, like 4 ml. So you're really limited in terms of where you're going to give it, especially if you're giving IM ketamine to an agitated patient. Trying to get to some of those other like sites that you're going to end up giving it somewhere in the thigh, like in your rectus femoris or in like the dorsal gluteal or vastus lateralis. Sometimes those are a little bit harder to get to. And then there's also our nice slide of all of our different needle lengths and gauges based off of where or what patients' ages are. So you just have to be cognizant of you're not going to use the same needle length for a little kid as you are an adult. So some medications that we are going to typically give via IM administration. So medications that always get given via this route are going to be epi, like EpiPens, and then glucagon. Those are like those primary routes. But we also have a lot of medications that we normally give IV that we can also give IM, like atropine, Benadryl, ketamine, ketorolac, fentanyl, methylprednisolone, morphine. You can actually give naloxone IM, which is not, I feel like, as commonly known because we like get used to giving it IN intranasally. We can also give Zofran IM. So next we have inhalation route, and obviously we don't have as many medications that can be given via inhalation, but it helps to deliver the drug directly to the site of action for some specific meds. And so we think about here albuterol, ipratropium. We can actually also give tranexamic acid as an inhalation, not typically in like an EMS setting, but it's a fun fact that I feel like a lot of people aren't as familiar with. And then it's going to help produce like a rapid onset of effect because we're delivering that drug directly to the site of action. The other advantage of inhalation routes is that you actually have a lot of vasculature in your lungs and it's a very large surface area. And so you do have like fairly rapid absorption, which is nice. Disadvantages, you do need additional equipment and you have to make sure like you have proper technique. So if you're giving a neb and the patient like doesn't have like your mask on correct, or isn't breathing correctly, that can limit how well that's going to work. That's really going to be most applicable to inhalers where patients have to have the timing right of when they're like taking a puff and breathing in and whatnot. And then additionally, some medications can be irritating to pulmonary tissues. So that's why we don't give all medications via this route. So next is intranasal, which is always a fun one that I feel like we forget about. And so one of the pros of intranasal administration is that because of the nasal mucosa being very highly vascularized and having a fairly large surface area, you do have really rapid absorption of some medications. And that anatomic location, like being very centrally located, is ideal for like some of our medications that we want to be centrally acting, things like midazolam, fentanyl. But not all patients are ideal for intranasal administration because of anatomic issues. So if they have unhealthy diseased nasal tissues, or recently had like vasoconstrictor use, so like if they were using oxymetazoline to potentially like help with like sinus congestion, that can decrease your absorption from an intranasal route. You also can't give large volumes via the intranasal route, and like the pH of the drug and like the lipophilicity, or like how well that drug crosses like a lipid barrier, is going to impact whether or not it works well intranasally. So the advantages are that it's going to have a rapid onset. You don't need a needle. You don't need aseptic technique because it's going in the nose. And so all of that can reduce time to administration. But the disadvantages is that we can't give all medications via that route. And we have to be careful about like our volume of administration. And you have to be careful of giving it via proper technique. So our big medications for intranasal administration are going to be fentanyl, naloxone, and midazolam. Actually, we can give ketamine intranasally as well, but that's not included in the EMS protocols, but who knows, maybe someday. But
We'll be changing our protocols. We got all kinds of stuff. We'll have to have a whole nother discussion.
So keys to success for intranasal administration. So if you have a patient that has blood coming out of their nose or a lot of mucus, suctioning first can be ideal to make sure that your drug gets to the delivery site adequately. You also want to use the highest concentration available for a medication, because that's also going to limit the volume. And so, because we have a limited volume we can give up there. Typically, when you're giving a medication intranasally, you want to divide your dose between the two nostrils. So if you have a 1 ml dose, you give 0.5 ml in the left nostril and 0.5 ml in the right nostril. And you want to make sure you limit your total dose to less than 1 ml per nostril. And then when you're giving it, atomization is like the most effective technique, so that mucosal atomization device. And when you're doing that, you want to make sure you you have to like go hard at it. You can't like depress that plunger like all willy-nilly, like, because it's just going to come out as like a little bit of little like squirt, and like it's not going to like atomize the way you need it to. So when you depress that plunger, you need to make sure you do it with force, so that allows for that full atomization and that mist to occur, and then proper drug delivery. So to summarize some of our routes of administration, we have similar effects with IO and IV. And then when comparing time to onset, you also have to think about your time to administration. So like your time to obtaining access. And so you need to think about your pros and cons. And if you're struggling to get an IV and you really need to give a medication intravascularly, start your IO. If you don't need to start an IO, but you need to get a medication on board quickly, think about IM or IN. And then ultimately, your ideal route is going to be dependent on your drug properties. And just remember that not all drugs can be given via all routes, but that there are more than your like conventional options available. Okay, so now we're going to get on to like the more like fun stuff, I guess. So midazolam and ketamine. So both of these medications like can have very similar places in therapy. And so when we think about ketamine, ketamine is a general anesthetic. And then when we think about its unique role in therapy, it provides analgesia. So we can use this for pain, including in the pre-hospital setting. Whereas midazolam is a benzodiazepine, and its unique role is going to be that it is really our ideal first choice for seizures in that pre-hospital setting. And then both of them, they have that shared effect of providing sedation and amnesia. So we can use both of these medications for like RSI and sedation. So For when we think about sedation, we can give both. We can also give both for agitation. So we're giving it like sedation, like a post-intubation sedation, but also like sedation for like an agitated patient. We can also give both for procedural sedation in that pre-hospital setting. Per the EMS protocols, ketamine is the only one of these two that you can give for RSI, although those of you guys that work in the hospital will know that we also will use Versed for RSI, and that's in our RSI kits here in the hospital. And then ketamine is also used for analgesia. Interesting, ketamine also provides anti-seizure properties as well. So even though it's not your go-to pre-hospital for seizures, it does actually provide some anti-seizure effects. But midazolam is going to be our go-to for seizures. So for ketamine, ketamine is a dissociative anesthetic, and it's going to work by antagonizing NMDA. And so that's going to block glutamate release. And as a reminder, glutamates are excitatory neurotransmitters. So we're blocking that excitation from occurring. And so through that, we're going to result in both sedation and analgesia. The analgesic effect of ketamine is also related to the fact that it actually acts on opioid receptors as well, which is why it can also be a benefit there. And then in terms of our routes of administration, we can give ketamine IM, we can give it IV or IO, and then, well, not in the EMS administration or EMS protocols, you can give it IN as well. So in terms of concentration, there's different concentrations available for ketamine, but the one that we keep with EMS is the 100 milligrams per ml, and that's going to be the concentrated formulation of ketamine. And the reason why we do that is to help minimize volume, because like I kind of alluded to earlier, if you have a really agitated patient and you are going to give 4 milligrams per kilogram of ketamine, IN, and you have a 100 kilogram patient, you need 400 mLs of ketamine, or 400 milligrams of ketamine, sorry, said that wrong way. So 4 mLs. So for comparison, I know. So for comparison, the concentration we use a lot of the time in the hospital is 10 milligrams per ml of ketamine. So imagine you need to give your 400 milligram dose and it's 10 milligrams per ml. How many muscles are you going to have to get to give your 40 ml dose? So yeah, all of them. So that's why for EMS, we carry that concentrated formulation to make sure that we're minimizing volume in case you have to give it IM. And so in terms of dosing, I kind of broke these down by the highest to lowest dose. So your highest dose of ketamine is going to be for agitation because you're giving it IM. You need a higher dose if you're giving it IM because of the way it gets absorbed. So you're doing 4 milligrams for agitation. You do half of that for RSI because it's IV push. So 2 milligrams per ml. And then for post-intubation sedation, you're giving about half of that. So anywhere from like 0.5 to 1 milligram per kilogram. And typically, as a reminder, you redose that every about 15 minutes or whenever you notice like patient is starting to wake up. And then for analgesia or like any kind of procedural sedation where like you have a CPAP and the patient like has a lot of anxiety or like resistance, that dosing is like half of the lowest dose of our post-intubation sedation, so 0.25 milligrams per kilogram. It's not specifically called out in the EMS protocols, but when you give ketamine for pain, a lot of the times your max dose is going to be somewhere around 35 milligrams, which makes sense because a lot of times, unless you have like a really massive patient, like, you're going to max out somewhere around that point anyway. And then in terms of your pharmacokinetics for your IV, for your anesthetic dose, you really do have an rapid onset of action of about 30 seconds. and then a duration of action of 5 to 10 minutes, which is why it's ideal in RSI because it's fast on, fast off. So in terms of ketamine side effects, the one bad thing is we have a large slew of them, including hypertension, tachycardia, and then the emergence reaction. That emergence reaction really tends to be what tends to be difficult, especially when you're giving ketamine for agitation. So you give an agitated patient ketamine, and then they could have like hallucinations and whatnot when they come off of it, which can make that agitation worse. You can also have like nystagmus, hypersalivation, and laryngospasm. I really like this meme on ketamine because like if you're especially like pain doses, or if you're giving it for like a procedural sedation, like patient is completely normal, and then like a few minutes later they're like way out of it, like really high and don't know what's going on. I had a yeah.
She says it like it's a bad thing. I don't know.
So this is a protocol for ketamine for pain management specifically. So as a reminder for where its place in therapy is, if you've failed opioids like your hydromorphone or fentanyl, at that point, that is when you can try ketamine for analgesic doses pre-hospital. So next we have midazolam or Versed. And so again, that's a benzodiazepine, and mechanistically the way it works is it's going to act on our GABA A receptor, which is going to increase the inhibitory effects of GABA. So GABA is like that inhibitory neurotransmitter. And so that's going to stop the transmission of those like signals, which is why it's going to help with seizures and cause sedation. And then in addition to that seizure, sedation and anti-seizure effect, it also is anti-anxiety, which is why we give benzos for anxiety. And then it can also produce muscle relaxation, which is a commonly forgotten like effect of benzos. And then in terms of routes of administration, we really have a lot of options here where we can give it IV, IO, intramuscular, and then intranasal as well. And that intranasal is per the EMS protocols as well. So in terms of dosing for seizures, post-intubation sedation and procedural sedation, the dosing is all going to be the same, which is nice because you don't have to remember a bunch of different doses. And so that's going to be 2 to 5 milligrams via any of the routes. So same dose for all of the routes, which makes it a lot easier to remember. So that's going to be the adult dose, and then pediatric doses are going to be 0.1 milligrams per kilogram via all of the routes. And then you have a max dose of whatever your adult max dose is. And then for agitation, well, you're probably not going to give it for this via an agitated patient. You can do 5 milligrams IV, IN, or IM. Most agitated patients are probably not going to want to try to give a medication intranasally. I mean, you could try, but I feel like a lot of patients, like, when they're agitated, don't want you going up near their face. But it is theoretically an option based off of the protocols. This kind of showed up funny on the slide, but like our onset of midazolam is going to typically be a little bit slower than ketamine. It's going to be an onset of somewhere between somewhere around 15 minutes and much longer duration. And where I say like your peak effect occurs somewhere around like 1 to 2 hours. And then when we think about side effects for midazolam, we have side effects. Our big side effects are going to be hypotension, respiratory depression, and you can also have paradoxical reactions where some patients, especially those that have hyperactive or aggressive, with aggressive behaviors, and some pediatric patients or patients with a history of alcohol use disorder, you might actually see these patients get more agitated when you give them Versed. It's not a super common reaction, but it does happen periodically. Okay, so this is the acute agitation protocol for EMS, and this is going to, our two options here are going to be ketamine and Versed. And so comparatively for specifically the indication of like agitation, giving ketamine IM versus Versed via any of those routes, our ketamine onset of action is going to be fairly rapid. It's going to be about 5 minutes. Some studies have shown like an onset of even less than that, of around 3 minutes. So that's really a quick onset of action to help with an agitated patient. And its duration is like fairly short. It's going to be around somewhere between 20 and 30 minutes. So we're not going to snow them for a really long period of time. And they're probably going to be waking up by the time you get them to the hospital. And so if they need resedated, it's probably someone else's problem at that point. But
They thought it, you said it.
Whereas for midazolam, when we think about like our pharmacokinetics, its onset's going to be about 15 minutes. So compared to ketamine, your patient might not end up having that sedation by the time you get to the hospital, but your peak effect is somewhere like around like 60 minutes. And so they're going to be good for a while, like when you get them there. So when we look at some of the studies for ketamine specifically in a pre-hospital setting, there was this 2016 study by Cole and colleagues that showed that ketamine had a significantly faster time to sedation compared to Haldol, which we don't have on these rigs. So that was like a difference of 5 and 17 minutes. However, and ketamine was also associated with less redosing. And then Cole and colleagues also did a study in 2018 and showed that ketamine had an average time of sedation of around 4.2 minutes, and that 90% of those patients did have adequate sedation. The downside is in that study, they found that ketamine had an intubation rate of 57%, which is a lot higher than we probably want it to be. And then there's also other studies that have found that there's a higher rate of pre-hospital intubation with ketamine. So it's kind of supporting that previous study. So when we think about acute agitation, we compare ketamine and Versed. There's still a lot of literature that's like being conducted, or like studies that are being conducted to determine like where, like the pros and cons of these different ones, and if there's one that's superior to the other. And there's actually one that is in progress that we've been kind of waiting to see when the results come out. But until we have a final conclusion, like when we think about our pros and cons, our big pros of ketamine are that we're going to have that fast onset of action. We're not going to be stuck in a small space with agitated patients for a long period of time because it will have that fast onset. And it can also be helpful in our hypotensive patients. However, some of the cons of ketamine is many people are less familiar with its effects. And it can also, with that increased heart rate and blood pressure, that's not always ideal in a patient that's already hypertensive or tachycardic. And so you want to make sure that you're selecting it in the right patient. And then you can also have that emergence reaction with it. Whereas for midazolam, one of our effects of it that is both a pro and a con is that it has that long duration. On one hand, it's nice to have a longer duration, but on the other hand, you don't want the patient to be out of it for too long. Midazolam also has many routes of administration, and there tends to be a little bit more familiarity with it. And then in terms of cons, midazolam is associated with more respiratory depression than something like ketamine. It does have a slower onset of action and can cause hypotension. So this is another one of our EMS protocols. And so this is the post-intubation sedation protocol. And so this is kind of where we can use some of those same pros and cons with ketamine and Versed in terms of selecting how you want to resedate your patient after intubation. So you can really choose either midazolam or ketamine. But as that reminder, like if you have an intubated patient that's hypotensive, that might be a good patient to do ketamine instead of first aid. Or if you have a hypertensive patient, first aid may be more ideal in that patient. So you kind of have to like look at the full picture and not necessarily just have, I'm always going to do Versed or I'm always going to do ketamine, and kind of make sure you evaluate that patient in front of you and make sure the side effects make sense and your time to onset is going to be ideal. Okay.
Any questions for Christine? Thank you very much. All right, guys, that's all I've got. Again, if you have not texted and or emailed me to let me know whether you were online or not, let me know, please. The next one will be Regional Hospital, second Tuesday next month.
Yep.
Other than that, anybody out here got any open business you'd like to talk about right now? There'll be some stuff coming out from the EMS advisory, nothing serious, just a few changes in the protocols, and new updated protocols should come out here in the next week or so. Thank you, guys. Really appreciate it. Have a good one.
Interesting.
Yes.